Testing 1, 2, 3. Testing 1, 2, 3. Can someone jump in there? Testing 1, 2, 3. Okay. Thanks, guys. So anyway, what we're talking about today is some of the crazier things I've seen on Facebook, and more recently, a little disturbing because I think patients see someone that knows presumably more than they do, and so they believe what it is they're seeing, and I want to show you how it all gets a little twisted when you start with a little bit of information and then you kind of twist it to meet your own needs, let's say as a clinic owner. So let's go through some of that. Apologize for the initial change in audio today. We've got some work being done on the house, and I was trying to make sure that you guys couldn't hear as much of that background noise as possible. But let me go and I'll share my screen and we will go and start taking a look. As always, you can ask questions about this topic. You can ask questions about anything at all. One of the goals of this show is to make sure that patients get their questions answered. I try to get on here twice a week if I can to make sure that people have the ability to get questions answered. And that really is especially true for a lot of my CCI patients. I want to stay available or as available as I can to them to make sure that they're getting their questions answered. So avoiding Facebook stem cell and PRP scams. So sometimes I pop onto various Facebook groups to see sort of what's being asked by patients, what's going on. That helps me judge what patients know and what they don't know, which helps me produce videos like this. It helps me write on the Regenix blog about timely issues to try to clear up misconceptions, etc. And I have to say, the amount of disinformation out there is pretty staggering to me. It's almost disheartening at times to see how little tiny bits of information get turned around, in particular by a lot of alternative health providers and a lot of clinic owners, into so twisted that they no longer really bear any resemblance to reality. So today I'm going to review 7 random posts to try to educate you guys on some of the things I saw this weekend. So let's start with this first one. The question being asked, and I've anonymized these to the extent I can. How many umbilical stem cells are needed for a lumbar injection per cc? Now, there's a couple of different issues here just in the question. The first would be that there are no umbilical cord stem cells available for use in the spine in the United States. If you were to try to purchase some, and you would be getting mostly dead cells. Now, this particular medical provider, who's not a doctor, meaning not in the sense that I would consider a doctor, an MD or DO who went to medical school, internship, and residency, he's actually a naturopath. But he tries to answer this question and goes through what he thinks here. He likes to administer 100 million, quote, stem cells, et cetera, et cetera. Now, this particular doctor, after looking him up, or naturopath, I should say, is trying to use culture expanded umbilical cord stem cells, which, based on all of the statements from FDA, would be illegal in the United States. And so I really like the patient's question down here. Do you do so fluoroscopically guided? What that tells me is the patient is trying to get some information. Whoever is asking this question knows a little bit about what's happening. And then Dr. Travis answers, not currently, but we will in May or June. Now, what does that tell me about Dr. Travis here? He doesn't have a clue, in my opinion, meaning that using fluoroscopic guidance and learning how to do interventional spine with fluoroscopic guidance is something that takes an entire fellowship. It's not something you go to a weekend course and learn. My guess is if he's going to use fluoroscopic guidance, he's going to use it like a clinic in Florida uses it, which is just to place the needles kind of in the vicinity of something that you want to inject without anything that would qualify as true interventional spine treatment. But I love this patient that asked this question, because River has the right question to ask here. Are you going to use fluoroscopic guidance? Now, the perfect question would be, are you going to use fluoroscopic guidance with contrast confirmation? That would separate out someone just using a fluoroscope to say they used a fluoroscope from an actual doctor trained in interventional spine. So this is an interesting one here. And I'll probably be kicked out of this Facebook group here for posting this, but I thought it was really fascinating. I was initially only going to do the left, but then the right happened after I posted. So this question is posted elsewhere, but trying to get clarity. Do intradiscal injections of MSC cells help you grow the disc? I see some clinics offer to do this and others do facet injections, or can facet injections help with disc growth expansion? So the answer to the question is no. They do not help regrow the disc. Now they can be useful in a few select clinical scenarios. But what this patient is finding is some will agree to do this and others not. Now, why is that happening? And as I go into in my answer, it's simply because the clinics that don't do this don't know how to do this. They're not qualified to do this. So we got Dr. Travis again here, the naturopath, answering. Many won't inject the disc as the tissue is tough and not a lot of room to inject a lot, which can lead to complications. There's more room to inject around the discs. Now, that's not even close to being medically or clinically or scientifically accurate. You can get about a cc of something into a lumbar disc, and that's more than enough to injectate in which to put cells in or platelets in or any of that. So that has nothing to do, Dr. Travis's answer there has nothing to do with reality. As I answer up here, the disc can be easily injected if the provider has the qualifications and training to inject that structure. And 99% of these clinics don't have that training. Hence, they come up with all sorts of machinations about why they can't do this. And next is an answer from a clinic owner in Mexico. Now, this is a little bizarre here. This is a clinic owner that's running the entire Facebook group for this Mexican clinic, and is answering these questions as if he were a medical provider, but he's not a medical provider in any way, shape, or form. He's just a business guy that owns a clinic. So he's saying, well, wait a second. On the one hand, you say that this is dangerous to do, and I've got these orthopedic surgeons working for me down in Mexico, and they won't even touch a disc. As I put down here, spine surgeons are not trained to perform disc injections. That's a specialized skill set, meaning that if a spine surgeon showed up at a course, I would reject them. I've already done that. I've rejected neurosurgeons, spine surgeons for interventional spine courses. That's an entire medical specialty that takes a fellowship to learn. You can't do it in a weekend course. But what's interesting to me about this one here is, again, we've got a clinic owner with no medical background whatsoever who is answering clinical questions. And I'm scratching my head saying, why is that happening? Then he doesn't even know that the surgeons that he's hired to do these procedures aren't trained to do a good number of them, obviously. So they're saying no to him, and then he's trying to concoct a reason why they're saying no. Another one, this one's more CCI related. I have a CCI diagnosis from Dr. Patel. Been trying Prola with Dr. Krasnak, MD in Ann Arbor. He uses ultrasound guidance. Wondering if anyone's familiar with this procedure. Now, the reason why I bring this one up is this is a common misconception that a lot of CCI patients get into. So if we just read the note here, a very short note, we can see that what is being represented as injection or as being injected probably never got injected. So it says all tender points were marked and sterilely prepped with Hybiclens under ultrasound guidance, 48 cc's of 25% dextrose, a little high. Normally we'd go to 12.5% dextrose, but whatever. used to inject suboccipital region, inion, nuchal ligament, upper C3 to C6 interspinous legs, C2 through T1 spinous processes, lamina, and C3 through C6 facets. Now, the likelihood that the facet joints got injected here is small based on how it's described. You would have to, if you were trying to do it under ultrasound, which would not be the preferred way, you'd have to say something like the C3 through C6 facet joints were prepped using sterile technique, and a 25 gauge 3.5 inch needle or 2-inch needle was directed towards the posterior lucency in the joint. A small amount was injected, showing good intra-articular flow. I injected X number of cc's per joint, et cetera, et cetera. So because it's not described like that, I know that what they really did was probably place the needle somewhere in the vicinity of the facets without actually injecting the facet joints themselves. And the preferred way to do that, to inject those facet joints, would be under X-ray guidance with contrast confirmation. Now, what's also interesting is I have a CCI diagnosis from Dr. Patel. And as we've talked about, that breaks into one of 8 subtypes. And there's only 1 to 2 of those subtypes that do well with posterior injections. So what is the subtype that this patient has? And was that discussed with them as to whether or not posterior prolo was a good fit? My guess, it was never subtyped at all. Here's another interesting one. Several members in other groups have said that PRP is a cover-up and not long-term healing. Please, can someone experience PRP share your thoughts on this? Again, this all depends on what it is you're treating. If you're treating mild arthritis, PRP is a great choice. If you're treating issues in the spine, PRP can be a great choice. If you're treating a small partial ligament or tendon tear, PRP can be a great choice. Where PRP is not a great choice is if you're treating severe osteoarthritis, or if you're treating craniocervical instability type 2B. So it all depends on what you have. And again, the patient doesn't know that. Now, thankfully, some patients jumped in and tried to get to that level of detail. But this is kind of what you see in these social media groups, a lot of patients that are very confused. Another question, I'm curious, has anyone gotten their stem cells frozen and stored? My local clinic says they can do the stem cell harvest once and then regrow them in the lab. Now, this is completely illegal in the United States. There's no doubt about this. Yes, stem cells can be frozen and stored outside of the United States. This can't happen in the United States. In addition, there's no way to get an infinite number of stem cells for the future. Even if it were legal to culture these and save them for future use in the United States, like we do down at the Cayman site, it would never be an infinite number of stem cells to use in the future. Why is that? Because adult stem cells have a limit on how much they can grow before they become unhealthy. So whenever you're growing cells in culture, you're threading that needle between healthy cells and getting more versus cells that have become bad because they've grown too long. So there's lots of problems here. Number one, this is illegal. Number two, it's just a fictional statement if that's what the clinic told this patient. This is a really interesting one. I kept the name of this one up. This is in Bangkok, Thailand. Now, as an expert, when I look at this, why does this make me say there's no way I'd ever go to this clinic in Bangkok or recommend a patient of this clinic in Bangkok, Thailand? Because if you look at what it is they're actually focused on here, it's a bunch of different stuff. And then they've got sort of as an afterthought, MSC stem cell injection. Where, how, with what expert? We already saw a Mexican clinic who didn't even know that it was impossible or that it was possible to inject the disc, because they have orthopedic surgeons there who aren't interventionally spine trained. I can't imagine what you're going to get in Thailand here. So there's another one for some of my CCI patients and EDS patients. Hey, everyone, advice needed. I have EDS, instability in lots of different places. Looking into prolotherapy, PRP, and stem cell. I've read prolotherapy is something that I have to maintain. PRP is a better option. Stem cells is better. My question is, someone with much of these issues would work best for long-term ligament stability of the spine. Is it safe to do in those spots? So there's a number of issues here, right? The first would be, sounds like she's saying she has CCI. And then we get into what kind of CCI, and that's got to be mapped to a specific treatment. Does she need the internal ligaments, alar transverse injected or not? Then we get into these thoracic issues that she has. And there are very, very few clinics that are qualified to do thoracic interventional spine beyond just sort of injecting the supraspinous interspinous ligament. So what's the diagnosis there? What does she need there? And then states like she's got some, or sounds like she's got some SI joint instability. Again, we got lots of different options there. We can inject the ligaments there, blind. They can be injected under guidance. Obviously, under guidance is much better than blind. They can be injected intra-articular using X-ray guidance. Is that needed? Is that not needed? Et cetera, et cetera. So I'm going to go to some questions now, but I wanted to just show you some of these things that I'm seeing out there. And I have to say, it's a little scary, meaning that we're seeing a lot of alternative health providers who seem to be trolling various groups, answering questions that, in my opinion, are way above their pay grade. And then we see clinic owners answering questions, and when it doesn't fit what that clinic has to offer, meaning on the types of doctors they've decided to hire, next thing you know, we're making up reasons about why this can and can't be done, et cetera, et cetera. So just wanted to share with you. I will stop the share here now, and we will go to some questions. And looks like we got a bunch of them as usual here. Let me go there. Okay, I think everyone can hear me now. Thanks for letting me know that. Let's see. So I was just curious about this research. A PT mentioned it and was trying to explain how important it is to do the right exercise, property create what's called scar. Yeah, I saw that earlier. It was sent to me by Carol, our social media person. I will go ahead and take a look at it in more detail when I've got a minute. So thank you for Andy. I know that you enter the C0C1 joint on the lateral portion posteriorly. If you were to keep the needle on capsule and inject, you think PRP will make its way to the medial portion of the capsule. You don't come at it medially because that could be dangerous. You come at it posteriorly, meaning from the back. A problem with trying to get the medial capsule is that you are going to risk entering the spinal canal and the brain stem. So that wouldn't really be a safe approach. You probably also risk taking out the vertebral artery as well. Now, if you're coming from the front, like in a PICL procedure, you could do the medial side. That would be a little safer to do because you've got more distance on your side there from the things you're trying not to hit. But from posterior, it wouldn't really be a safe thing to attempt. Arno, how successful is the PICL procedure? Actually, what percent of patients that are chronically ill actually get life-changing benefits, would you say? Yeah, Arno, I think I've said many, many times here, I think I've showed the data from our round 2 data collection. It's about 7 out of 10 patients that are responding. That response can be everything from, patient going from having to lie down all day to being up and doing more, to patients that are going back to doing exactly what they want to do, including athletically. The depth of the hole, meaning the number of years the patient's been bedbound, for example, makes a big difference in the final outcome because, as you might imagine, if the hole has been dug very deep, by being that deconditioned, it takes a long time to get out of that hole. So 7 out of 10 is what we quote, and the last data analysis we did seemed to support that. So I think my overall sense seems to be supported by the data we've collected so far. Howard, PRP worked incredibly well for my neck, but absolutely nothing to help with ruptured disc. Yeah, Howard. So again, I'd want you to ask the same questions that I was talking about in the presentation. What did they do for your ruptured disc? Was the disc actually injected? Did they not inject the disc? Who injected the disc? Where in the disc did they inject? In the annulus and the nucleus? Did they also inject the functional spinal unit around the disc? What type of PRP was used? What leukocyte poor, leukocyte rich? What concentration of PRP was used? As you can tell, there's a dozen questions there that all determine your outcome and haven't been asked at this juncture. So hard to say why it didn't work, and it maybe was never going to work even if it was done the best because of the type of disc issue you have. Ulysses, they're protherapists who be scamming people too, like who does blind injections. Yeah, I would agree, Ulysses. There's lots of doctors out there who are not really doing what they claim to do. And it's a problem for patients because how does a patient know? Only through information like this can some patients, like the one you saw, start to ask the right questions. Do you use fluoroscopy? Oh, no, we don't use fluoroscopy right now. Well, you claim to be doing spine for years. How could you not have used fluoroscopy? Oh, we're buying one here this summer. Well, you can't just buy a machine, right? You got to learn how to use that machine. You'd have to go through an entire fellowship to learn how to do interventional spine injections under fluoroscopy. So again, those are the kinds of questions I want you to get educated and start asking. And what you'll find is it's pretty crazy out there. Andy, if you were to place your needle specifically in the posterior capsule of the 0-1 joint, inject 1 to 2 cc's of PRP, unlikely that we could guarantee that it would spread to the medial portion of the posterior capsule. But again, unlikely that that would probably make the difference for the patient, meaning if we're relying on the medial portion of the 0-1 facet capsule to stabilize the neck, for instance, the alar ligament's already shot. So without getting the alar ligament, all bets are off in that clinical scenario. Lloyd, my wife Elizabeth just went surgery for Chiari 15 minutes ago. I'm now waiting for 4 hours for it to be finished. You took the time to go over her MRIs and imaging with us. It was wonderful. You're the most thorough image reader that we ever come across. I wanted to thank you very much for help you gave us. Your clinic's a godsend and benefit to the world. Well, thank you, Lloyd. And I think I remember the case. I won't go into it here clinically because I don't want to reveal confidential health information other than to say your patient, your wife needed surgery. And that's what we said. And I thank you for pointing out that I spent a lot of time reading my own films. And I do that because when you rely on radiology reports, you're relying on someone else to tell you what's wrong. And that person, meaning that radiologist, may not be looking for the same things you're looking for, which is why if you're in this field, you've got to learn how to read your own images. And the more time you spend with those images, the more time you spend with the patient, the more likely it is that you'll figure out what's wrong. Bethany, higher Centeno, if the ligament flavum has hypertrophied, how many injections or treatments does it need to be repaired? I just had my second injection for ligament flavum on my PCL last week. Wonder if I might see results second time around. Yeah, Bethany, I think in many cases, we see a hypertrophied ligament flavum in addition to a disc bulge. So hopefully injecting the ligament flavum would help. How long would it take to see results? Usually in the 4 to 6 week time frame, somewhere in there. And the goal is to strengthen the ligament flavum in that clinical situation. Let's see, why do people put stem cells near me on Google? In fact, they'll get scammed by this person. Oh, Yeah, listen, there's a lot of crazy advertising out there. We got lots and lots of people advertising lots and lots of things. Many times, in my experience, they're not even offering stem cells. They're just offering some birth tissues, which don't really have any living functional stem cells. So you're right. Regenix, submitted advanced by Sherry. Shouldn't there be some kind of regulatory agency that prevents this misinformation? Yes, there should. I mean, the problem is, and I'll tell you, because I've been fighting it now for almost 20 years. Actually, that's probably too much. Let's say for the last 12, 13 years, because when I started doing this almost 20 years ago, there was no one else on earth was doing it. So it wasn't until we started to see other people do it, and the misinformation really got ramped up around 2015. So really got bad for the last 7 years. The FDA tries to do what it does, but it's understaffed and overworked. So it'll never get to all the doctors claiming all sorts of crazy things. State medical boards should be acting much more harshly in this area. And we've seen MD medical boards get a little bit more active, but then you see naturopathic boards, chiropractic boards. The naturopathic boards, in my experience, are the worst. They don't really care. I've complained to naturopathic boards. I've complained about naturopaths operating outside of their legal scope of practice. Got nowhere with naturopathic boards. Chiropractic boards are a little bit better. We've had a few chiropractic boards that have acted, or at least tried to act, but all medical boards are a little bit behind the 8 ball, because you've got a doctor making a lot of money who can hire really good attorneys going against an understaffed and overworked medical board. So sort of the same type of thing. So regrettably, it's the Wild West, and patients need to protect themselves. Thatcham, what short rotation left right of the head, or with short rotation? The rotation is too smooth, it's a sign of ligaments laxity. I don't know what you mean by too smooth. You'll have to clarify that one. What does a sports medicine doctor do? Yeah, this is a good point. Sports medicine doctors, with regard to non-orthopedic surgeons, would be doctors who specialize in the conservative treatment of joint problems, peripheral joints, hands, knees, elbows, hips, ankles, those sorts of things. Generally, they don't have any training at all in how to deal with the spine. Now, a few sports medicine doctors have kind of realized they're behind the 8 ball here, because there's a lot of patients that want spine orthobiologic treatments. And so a lot of them try to bolt on some spine, but they do a bad job at it because they're not trained in interventional spine. They never did a fellowship for interventional spine. They wouldn't know how to inject a facet under C-arm fluoroscopic guidance with a contrast if I held a gun to their head. So they kind of fake and bake the spine part. And that's, again, something to know, that if you see someone describing themselves as a sports medicine physician, probably, and not always, but probably you don't want to get your spine injected there. Kimmy, thank you for being patient with all of us. Sometimes I feel like I'm continually asking the same questions on these Facebook Lives because I want to be 100% sure. Being an advocate is so hard. We appreciate you. Oh yeah, Kimmy, always happy to answer lots and lots of different varied questions out there. Been to your clinic for PRP bond twice. I live in Silver City, New Mexico, and I'm having a problem with my shoulder. Southwest bowling joint. I'm assuming that's an orthopedic practice. Did a PRP injection on my shoulder. If I hadn't come to you first and understood what to do beforehand and what to do after being out of work, they didn't know anything about not having me on NSAIDs or taking me off statins or anything, but because of experience with the knowledge, helping getting a help PRP shot. Well, thank you, Lloyd, for saying that. Yeah, I mean, again, you've got a lot of orthopedic practices that are kind of bolting this on, and they don't really understand which is up. So thank you for recognizing that. Ulysses, what are the types of PRP you use at your clinic? All depends on clinical problems. So for instance, we talked about intradiscal. For intradiscal, we'd use leukocyte rich 20x concentrated. For a 25-year-old with a bad knee, 3x leukocyte poor. For a 55-year-old with arthritic knee, if it were mild, we'd be using 14x leukocyte poor. So as you can see, it all depends on the clinical situation and scenario in which we find ourselves. And that's critical to understand. It's critical to understand that it really depends on the clinical scenario. So if you ever go to a clinic that's got a one size fits all approach, we take your blood, we throw it in here, something pops out, we inject it, and they're not tailoring that PRP dose or type based on what's wrong with you, it's time to run out the door or at least walk politely. Jim, do you think muscle atrophy weakness can make the brain perceive a mild lax ligament as bothersome, whereas if the patient has no muscle atrophy, a mild lax ligament is not bothersome? It's a good question, Jim. I can certainly say that, as we talked about before, that muscle stability is absolutely a key part and portion of getting to a stable joint or section of the body like craniocervical junction. So I would surmise that if someone had mild instability but were really strong muscularly, it wouldn't really be perceived as a problem. And that's one of the reasons why we often talk about it takes ligaments and muscles to get to stability. So I can help you with your ligaments, and only you can help you with those muscles. Ulysses, is it important to see a neurologist for spine issues and will focus on ligaments too? No, in my experience, Ulysses, regrettably, most neurologists are pretty clueless when it comes to ligament issues in the spine. It's just not part of their training. Now, we have the one exception to the rule, or the the very rare exception of the rule. We've got a neurologist now who is in our fellowship program, Dr. Gaddis. And Dr. Gaddis gets it. Dr. Gaddis understands it. So he's accepted as a fellow in our clinic. And that's rare among neurologists. He'd be the first to tell you that. Regenix mid-advanced by DB. How can you tell whether something you hear on Facebook about stem cells is true or not? You can't. Well, that's not true. You can, if you continue to watch this show and you learn, you can start to sniff out the craziness. Like the one patient who asked the naturopath, who lists himself as Dr. Travis. So he's not an MD specialist. He has no medical doctor training, has not been through a residency, has not been through a medical internship. He's not been through a fellowship for interventional spine training. And that patient sniffed it out pretty quick. They asked, do you use fluoroscopy to inject? Now, a better question would have been fluoroscopy with contrast confirmation, but it was close enough. And it sniffed it out pretty quick. The answer was no. But we're getting it this summer. Well, what's been going on for the last couple of years? You've been injecting the spine without fluoroscopy. Why are you suddenly getting it now? And don't you have to do a fellowship to learn that stuff? You're a naturopath. You're not eligible for interventional spine fellowships. So the answer is there isn't an easy way to do it, which is why we're talking about this today, right? Ulysses, do you use prolotherapy in your clinic or do you stop using it anymore? Nope, still use prolotherapy. Prolotherapy is a nice technique that's inexpensive. And in fact, there's probably not a week that goes by that I don't use prolotherapy for some ligament issue. We would only use it for ligament issues, but it's really a great little technique. There's no reason not to use it or to throw it away. Robert, thank you for educating and warning all the dangerous money-wasting facilities. Shame that egos try to defame you, yet with no scientific rebuttal. Oh, yeah. Well, I'm sure, listen, Robert, I am not real highly thought of if you're a naturopath or a chiropractor offering scam stem cells, etc. So I'm quite sure of that. But I will take that as a compliment, meaning that I work hard to educate patients. And I've yet to see any of those folks actually publish anything in this space. Obviously, I've got almost 50 publications in this space right now, which is many, many more than 99% of the universities out there in the field of interventional orthobiologics. Kimmy, I'm looking at a hysterectomy this summer, not emergency. I'm also needing posterior PRP with you. Would you recommend waiting until after the hysterectomy or doing injections before? How long would you recommend waiting for procedures either way? So I would think that you'd want to put at least 6 weeks after the hysterectomy before you got posterior PRP, and vice versa, same thing. Put 6 weeks for PRP and then a hysterectomy. You want to have some distance there, and the biggest reason is more so when you're unconscious and they're moving you around. In these types of surgical procedures, that's when things can get injured in the neck. Jim, when my back is supported on a chair, my head feels a lot less heavy. Also notice that this has engaged my back, scapular muscles without any support from the chair. It feels less heavy. Yeah, I would assume, and again, this is an assumption because I've not performed an exam on you, that what you might be seeing is the chair is actually improving one of two things: your posture, meaning you don't have quite as much forward head when you're sitting in a chair as you do when you're standing, and that's going to take pressure off the high upper cervical spine. Another option is you're getting stability in the thoracic spine by pressing against the chair, which you lose when you're up. Bethany, are symptoms of numbness and weakness in arms, biceps, and hands more likely due to CCI or core compression? Yeah. Bethany, you would need to give me permission to talk about your case here, because I know the answer in your situation. I think we've talked about that a couple times. Ulysses, another question: why do doctors like mixing prolotherapy with anesthetic in the neck or any parts of the body? I think doctors do that mostly just for comfort, to try to help the patient walk out with not too much pain. Regenics mid-advanced by Harry Winston. I must say I've noticed much more what I have learned is misinformation on American Facebook websites than UK. Any idea why? Yeah, my guess would be that the cash healthcare market is much, much more developed here in the United States, which then creates more misinformation out there. You also have a lot of private clinic owners that are not clinicians here. And that ends up creating problems, right? Because you've got a business guy who is involved in healthcare. So that's probably why you're seeing that trend. But thank you for that information. I didn't know there was a difference. Jim, if I'm correct, you can improve the tensile strength of ligaments through strengthening exercise, but exercise cannot tighten short and loose ligaments. Yeah, so Jim, you're right. The body with normal ligaments responds to load and eventually will increase the strength of the ligaments or tendons, and that makes them more durable. Now, if the ligament is loose and lax because it's been partially injured, then not going to really change things to get stronger, meaning the ligament is going to respond in the same way. In that case, you get one bite at the healing apple. If it's not completely healed, you need something to stimulate that again, like prolotherapy, PRP, all the stuff we've been talking about. Arno, thanks, Doc, for the info. Selfless work, very much appreciated. You're welcome. It is a little selfless. I got to say, I woke up today at 4 and started working on this stuff, and I just, again, I'm always blown away by the stuff I see out there. It's a little frustrating sometimes. So maybe this is my personal catharsis. I don't know. Rhonda, what imaging testing diagnosis lacks ligaments in the low back, SI joint, pelvis, hip area? Which ligament would most likely be lax and cause issues of instability? The most common one for women is usually the SI joint ligaments. Now, there's no great way to test that. If it's a lumbar issue, meaning low back, lumbar, then you can get flexion extension MRIs or flexion extension X-rays, and those do a pretty good job of finding unstable levels. But when it comes to the SI joint, we're not really going to see much on imaging when it comes to instability. That's more of a clinical diagnosis. Allison, it's very frustrating because most of us are desperate for relief and answers. Yeah. Yeah, I agree, Allison. It is very, very, very frustrating out there. And I understand it's because of that desperation that patients are falling into these traps time and time again. And so I don't blame the patients. I really blame the misinformers, meaning they're taking little tiny bits of information, twisting it so that it provides the sale, if you will, to hook the patient, rather than talking to patients in reasonable ways. So, for example, when we talk about whether a procedure will help or not, this could help you, for example. I think I may be able to help. Here are the odds that I might be able to help. Those are all reasonable statements for a doctor to make. But you see on Facebook, many of these folks doing things, and maybe this is one of the things that you should look for is over promising. I can cure you. Uh, this will work 100% of the time. Everyone gets better. Those are all red flags in medicine that doesn't exist in medicine. So just be careful. Corinne, I had my atlas adjusted again. Even when I'm, quote, I'm symptomatic. Currently have choking sensations and head pressure. Does it make sense to take a PRI approach before injections? Or is there any way to prep my body? Right now, in addition to damaged ligaments, I'm in a compensation pattern, so it feels like a physics issue. Thank you. Corinne, to answer that question, I'd probably have to take a look at you physically to see if there are biomechanical issues that could be worked on and what's compensating for what. Now realize that, being in or not can be subjective based on that particular provider who you're seeing. So we've certainly seen different levels of expertise in AO and NUCA. So one thing you might consider is seeing someone like Dr. Rosa, who's an expert in upstate New York, who can look at all this stuff and try to see if you're getting the right care when it comes to adjustments, or obviously, get diagnosed to see if you've got the kind of thing that will respond to adjustments or kind of CCI. Robert, if a patient has excessive growth of collateral vessels that completely block the 0-1 joint, does it prevent injecting this? No, Robert, I know which picture you're talking about. That patient sent that to me as well. It wasn't actually blocking the 0-1 joint. It was the angle in which the 3D reconstruct was done. If you change that 3D reconstruct from looking up towards the 0-1 joint to looking slightly down at the joint, you'll see it's not blocked, that there's a window to inject there. So no, that's usually not an issue. The big one to obviously be concerned about is the vertebral artery, and that's an important one. In fact, I might do this Fridays on that particular issue. That might be worth doing. We'll see. Jim, can muscle atrophy proprioceptive deficits cause extra tension on the passive stabilizers and cause the brain to perceive them as loose? Yeah, I mean, proprioception, atrophy, all of those things can cause a sensation of instability without there being an actual loose ligament. Arno, I still cycle to college and do weightlifting at home, significant amounts, even though it feels bad. I'm trying to not to get deconditioned. So unlikely respond positively to PICL. Yeah, I mean, all I can say is I don't know what's clinically going on with you and whether or not you're a candidate for PICL, but assuming you are, and you had some sort of common type of instability, let's say type 2B, then you'd be in a category more likely to get back to high functional levels. Kimberly, hi, I had dry needling done on Friday at a clinic specializing in EDS, CCI, the scapula area right and left sides, and have a lot of pain, muscle spasms, pain, running up to neck and jaw. What is your opinion on dry needling? Yeah, so Kim, in CCI patients or in EDS patients, they need stability desperately to provide, or I'm sorry, they need muscle spasm to provide stability. I misspoke. So IMS or dry needling works by getting rid of trigger points or areas of the muscle that are tight. So you're really taking away quite a bit of spasm when you're doing IMS. Now, in the normal patient, that can be very, very helpful. But if you're an EDS patient, you need all the muscle spasm you can get. So we often see that IMS, dry needling, or Botox will negatively impact that patient population because making the muscles loose is a bad thing for them. They need all the muscle tightness they can get to provide stability. So it's pretty common that we see that. Regenix, been advanced by Amelia. Is there a way to treat more than one issue, one appointment, for instance, SI joint and low back? Yes, not a problem. Lori, the other place beside you that I had a PRP injection, give me proper care instructions for before and after. The only reason it worked is because of you. Well, thank you, Lloyd. And I wish your wife the absolute best here. I know it's that very difficult time when she's still in surgery. No one's come and talk to you. So I wish her the best, and I'll put her in my prayers. Andy, do you think a mildly lax one joint capsule with normal strong iliac ligaments with the cause of heavy head feeling, or would it be a motor control issue? I have mild muscle atrophy on MRI at C2. Andy, I'd need to see more data, a DMX, flexion extension MRI, that kind of stuff to answer that question. In general, do I think a mildly lax 0-1 capsule is likely the cause of instability? Probably not. Now, it could be other things like the shape of the condyle. That's been more associated with problems. So there may be a flat condyle that's causing the joint to be more reliant on the 0-1 facet capsule and our alar ligaments. Bethany, following a previous question of 5-6 disc bulge does not respond to overfill the facets and ultimately needs disc replacement surgery, we're replacing the disc, helping hypertrophy ligament flavum at that level. In all likelihood, they'll probably decompress that level, so the ligament flavum would go away. It would be taken out in many cases. Stephen, I've had CCI for 3 years. I've met so many people who've had almost the same symptoms as me, but no CCI. I think that also, therefore, very many myths come to how do you see that? Yeah, I would agree, Stephen. I mean, that's why we take such a long time and put so much care into a CCI diagnosis, meaning that you have to, and I'll go through this again, but I go through it frequently on these shows, and that is you have to have, classic CCI symptoms. That's got to be matched with a physical exam that shows and localizes to the upper cervical spine. That's got to be matched with imaging that shows CCI. That's got to be matched with appropriate responses to treatment, etc. Only when all of those things are included can we get to high confidence of a CCI diagnosis. CCI symptoms by themselves have lots of overlap with other problems. Tamara Henna Violet, have moderate cervical stenosis at 5'6", having many issues, and thinking coming from the upper cervicals. What kind of doctor do I see to help me get a diagnosis on this? Yeah, few and far between. Tamara, we're happy to do a telemedicine consult to try to get there, but this is not a knowledge base that most physicians are going to have much expertise in. So I'm not quite sure I can help you with any specific recommendations there. Fatchin, there are some videos online about a physical exam technique to judge for iliac transverse ligament laxity. It could have potential as an additional diagnostic tool. Yeah, I saw that, and someone sent it over. I think the biggest issue there is that if someone has true CCI and you do that, you can make them pretty sick. So listen, I've tried lots of different manual techniques, doing PA springing of the atlas, of C2, tried to go ahead and test specific upper cervical segments. If someone truly has CCI, they're gonna, turn over and barf on the side of the bed. So because of that, I tend to stay away from those manual things because I'm trying to build trust with my patient, and I don't want them to do that. And I've done that more than once, meaning used too rough an exam technique in a patient who just couldn't tolerate it. Rhonda, referring to previous question about neurologists, a functional neurologist pointed me in the direction of CCI. Several neurologists I saw were definitely not aware of this condition. Yeah, I think what you're talking about there is more of a neurologist who's decided to pursue functional medicine, being completely different than a neurologist that we were talking about before. John, if I'm correct, a naturopathic doctor performing injections is basically a doctor who wasn't smart enough to get into MD-DO's medical school and wants to take the easy way out to perform injections. Yeah, you said it, not me. Um, yeah, there's no doubt that the bar to become an MD or DO physician is high, right? You got to go through 4 years of medical school. You've got to be a superstar. I'm sorry, 4 years of college. You got to be a superstar in college in order to get picked to go to medical school. So probably an acceptance rate and the average medical school of 1 in 10, something like that these days. And then you've got to work your butt off for 4 years of medical school. You got to work like a slave during internship. You've got to then work like a slave during residency for usually anywhere from 3 to 5 years. Then many times you have to go to fellowship for another 1 to 2 years. So it's a long haul that accepts only the brightest students that make it through all of that insanity. Naturopathic schools don't have that kind of acceptance criteria, nor do they have that kind of long road education. So it's a completely different gig as far as qualifications are concerned, as you're bringing up. Ara, how many injections of prolotherapy needed to see improvement in a stable ankle ligament? Well, you wouldn't do prolotherapy in an ankle ligament that was stable, only one that's unstable. If you have ankle instability due to loose ligaments, then it really depends on how loose, how you respond, but somewhere between 2 to 4 injections should get it done. John, if getting a peripheral ligament treated shoulder capsule or ankle ligaments, is it safe to use a mixture of 50% dextrose, glycine, 1% phenol, P2G? Yeah, we don't use P2G. We don't see a need for it these days in the world of PRP, meaning that P2G is incredibly toxic to nerves and incredibly toxic to other tissues. It is certainly a powerful proliferant, but in the world where there's PRP and P2G was used before we had PRP, there really isn't a reason to go from 12.5 to 15% dextrose to P2G. You would just go to PRP. Yeah, Bethany. So again, as we've talked about, I think it's mostly that C5-6 disc. The ligament flavum may certainly play a role. I am certainly hoping that what we did works for you, but you may well need to get that disc size reduced. Of the different options, a muscle-sparing microdiscectomy would probably be the best. I'm not a big fan of artificial disc replacements, as I think we talked about. Ulysses, which gender gets CCI the most? Probably women, just because there are more women with HEDS. Ulysses, when you tell a doctor you have neck pain and the first thing they offered you is steroid injection, yeah, I don't think that's a good idea for the vast majority of patients. Darian, I know stems can't really regenerate reticular cartilage, but what about the hip labrum? It's made out of fibrous cartilage. We're seeing Regen's video talking about this being possible. Yeah, so Darian, have we seen patients who get a reduction in tear sizes on MRI after hip labrum injections of things like bone marrow concentrate or PRP? We have. So that's one where you're going to be more likely to heal that labrum. Arno, thanks, Doc, for the answers. I understand that for you, there isn't much of a gain except a sense of virtue. So thanks for taking an hour of your time. Yeah, Arno. Yeah, I mean, like I said, my catharsis, because some of the stuff I read and I'm like, oh my God, I can't believe they're putting this down here. But thank you. Appreciate it. Sure, Kim. Ulysses, how come you don't do the type of testing in your clinic like Ross Hauser, for example, DMX or cone beam CT? Well, cone beam CT isn't a way to diagnose instability, so that's why we wouldn't do that one. We don't do DMX because we've got a really good provider locally here that does it well. Now, obviously, if we were solely focused on the financial equation, we would just do it ourselves, right? That would bring that income into the clinic. But I don't want to do that if I've got a provider locally who I know does a really great job. That would be Dr. Katz. So that's the reason why we don't do that. As far as offering some of the other tests, like ultrasound of the internal jugular vein, we don't have enough research to show that that's a valuable thing to do, as I think I've discussed in other Facebook Lives. So we're a research-based clinic. We focus on what's supported by the research, but we're open-minded so that we look at lots of different things that many clinics won't. Lloyd, would PRP be helpful for my wife post-surgery to assist healing? Certainly may be. Let's give her a couple months to calm down and get everything to heal, and then reach back out, and maybe we'll take a look over a telemedicine. Nolan, for intradiscal stem cell injections, would 10 million stem cells be 10 times more effective than 1 million stem cells? Do all chronic discs typically require multiple cell treatments? That's a complex question, but let's try to break it into, that seems simple, but let's try to break it into some parts here. 10 million of what? So for instance, are we talking about 10 million nucleated cells from bone marrow? Are we talking about 10 million culture expanded cells from bone marrow or adipose? Are we talking about 10 million nucleated cells from a fake stem cell procedure here in the US from a vial of Wharton's jelly? Are we talking about 10 million culture expanded umbilical cord cells, which would be illegal to use here in the United States? Are we talking about putting these in the disc annulus? Who's telling you they're putting them in the disc? What is that person's qualifications, et cetera, et cetera? I'm just trying to get you to understand the right questions to ask, because the way the question is formatted doesn't have enough information to get to any kind of scientific or clinical conclusion. Jim, when performing craniocervical flexion to strengthen deep neck flexors, if I'm correct, you were working on the upper fibers of the deep neck flexors cranial to the cervical, close to the craniocervical junction. Yeah, but there's another way to do deep neck flexors, and that's with a bladder back here. And you're trying to flatten the curve and put pressure on the bladder, like a blood pressure bladder, in which case you're getting the lower or inferior fibers as well. Nolan, for intradiscal stem cell injections with stem cell, I think you've asked that already. Again, I just trying to help you understand how not to get scammed. And just the way you've formatted the question, there isn't enough information there for you to avoid getting scammed at this point. Mark, did you mention correlation of vitamin D deficiency and flare-ups? I didn't. There's certainly lots of information that vitamin D insufficiency is a pretty bad problem to have, though. Ulysses, trigger point injections and toxic to muscle. Yeah, there's really no reason to perform a trigger point injection right now with anesthetic other than for diagnostic purposes. It's really the needle that does the work, not what you're injecting. Nolan, 10 million culture expanded from bone marrow compared to 1 million culture expanded from bone marrow. So the average, now the next question would be, are we talking about hypoxic condition, not hypoxic condition, US injection, not US injection? If it's a US injection, it's illegal and I can't comment. If it's an ex-US injection, I'll be happy to comment. I think ethics, morals, and having conscience most important. USA has become lawless, opportunistic, psychopaths, sociopaths, narcissists, or sad live. Well, thank you, AM. Yeah, no, and I think I answered this one, but just in case we get cut off, because I'm starting to wind this down, the answer to your question is not really, no. 10 million cells wouldn't be 10 times more effective. 1 million culture expanded stem cells is a lot of stem cells. That's more stem cells than you would get in 99% of all bone marrow concentrate procedures. So that's a lot of cells, but how the cells are grown makes a big difference. We're talking about early passage cells, late passage cells, hypoxic condition, not hypoxic condition. What were the cells grown in? Your own platelet lysate, pulled platelet lysate, fetal bovine serum with TGF beta added. Lots and lots of questions to be answered there. Jim, you wrote a blog post on patient you examined with extremely weak deep neck flexors due to prolonged neck collar use. She couldn't hold her head up. She responded well to a GOSCU. How did she do? Jim, regrettably, maybe I'm getting to be an old man. I don't remember that one exactly, so I apologize there. Sure, Bethany. And again, I want to make sure everyone understands you're always free to reach out to me if you're a patient via email. So if you've got any questions, you've got issues that aren't getting dealt with, we had a patient with like that today, please reach out to me. We work as a team in my clinic. So that means that we've got people that are helping us in the procedure. I've got Carla, my personal assistant. We've got the call center. Everyone's working as a team. And if for some reason you're not getting your questions answered or something's important and slipping through the cracks, as your doctor, just reach out to me. I answer dozens of patient emails a week because I'm trying hard to make sure that everyone gets their questions answered. Diana, hydroxynteno is ceftriaxone harmful to ligaments. It's okay to get PRP if we're just on IV ceftriaxone. I believe that a Florida shouldn't be, no, not the same way in which a fluoroquinolone would be. My physical therapist, Keith, has major spine damage from an accident. He has major neuropathy in his leg and recommend you in your clinic, especially you. He is going to send you images, treat him well. We've got the call center level. Sure. Yeah, Lloyd, happy to try to help. FYI about seeing multiple repeat comments that happened where I've accidentally posted a comment and not been able to edit or delete it. Sure. Yeah, I'm sure this system here is not perfect by all means. Okay, guys, thank you so much for watching today. I'm going to start wrapping this up because we've been at it about an hour right now. Again, I'll be here this coming Friday. And I will be on Monday and Friday here, probably next week as well. And then things get a little strange right before I leave for my 6 weeks off. During that 6 weeks off, starting April 22nd, I will go ahead and be releasing weekly videos. I already have those. Those are done. I just need to record them. And I'll be doing some more impromptu type Q&A sessions. Topic today was just social media craziness. Let me just answer a few of these here. Garrett, I think the PICL guidelines say to stop fish oil 3 days prior to the procedure, that I apply for fish consumption in general. No, Garrett, just realized that in my practice, Centeno, we've now changed that to a week. So Carla and I just made that change. A lot of that has to do with the fact that we think we're seeing excessive bleeding still in patients who have only stopped it 3 days before, at least in some. So we want you to stop it for a week. Now, listen, if you're an avid fish eater, then, meaning you eat fish morning, noon, and night, then yeah, you might need to stop that as well. But the average American is getting nowhere near that amount of fish oil in their daily diet. You're happy to help. Diana, I won't have time to see Dr. Rosa for alignment before my PRP. Is it okay to see you without an adjustment? Sure. Yeah, that's fine. Sure, guys. Always happy to help. Again, I'll be here this Friday. I will be having I'll have a new topic at that point. You all have a wonderful week. And thanks so much for watching today and for your support.